Sickle cell anemia. Normal hemoglobin is replaced by an abnormal sickled hemoglobin. They are elongated, crescent, or sickle in shape. This is an autosomal recessive disorder. 1 in 12 African Americans carry the trait in the United States. If both parents have the trait, they have a 25% chance of having a child with sickle cell anemia. We see this mostly in the African American population, and then we also see it infrequently in the Mediterranean descent. The pathological changes because of this sickled RBC, we have increase in our blood viscosity, and we also have an increase in our RBC destruction. Because we have an increase in the blood viscosity, this leads to thickened blood. When we have thickened blood, it slows the circulation, it causes capillary stasis, and then it has the potential for causing an obstruction or thrombosis. Most acute symptoms occur during sickle cell crisis. A sickle cell crisis can be precipitated by a few different things. It could be precipitated by an infection or fever, which increases the need for oxygen. It could be precipitated by dehydration, which also leads to increased viscosity. It could be precipitated by cold, again, low oxygenation, because when we're cold, we have vasoconstriction. Any type of stressor can precipitate a sickle cell crisis. High altitudes and poorly pressurized airplanes can cause a sickle cell crisis, again, due to the decreased oxygen level, which would lead to vasoconstriction. Sickle cells can resume normal shape when we hydrate or reoxygenate. The cell life is shortened, though, to 10 or 20 days with these sickled cells. The normal cell life of an RBC is 120 days. There's a little comparison of a normal RBC versus a sickled RBC. Diagnosis of sickle cell anemia is typically after 4 months of age when the fetal hemoglobin stores become diminished. Usually we see a diagnosis following a crisis such as an upper respiratory infection or a GI infection. There are different screening options available as well. The treatment, there is no cure currently. The aim is to prevent crisis. Again, we prevent crisis by making sure they have adequate oxygenation, adequate hydration, and prevent infection. How we manage a crisis, some of the things we implement is bed rest. We want to minimize their oxygen use, hydration, IV therapy, electrolyte replacement, pain management, blood transfusions. That helps treat anemia, and we would give antibiotics if we're treating any infection. When we do run into some dangers if we're giving multiple transfusions. Don't forget sickle cell, we said it's diagnosed in infancy, and then it will go on throughout their lifetime, and they live into adulthood for sure. That's possible. So again, we're talking multiple blood transfusions over the years. So some of the dangers from those, hepatitis, hemosiderosis, that's when iron is stored in the tissues. So iron is not stored in the correct spot, it's stored in the tissues, and that's called hemosiderosis, Hemosiderosis. And then we've talked about this before, the more you're exposed to something, the more likely you are to have reactions. So there could be some reactions. Complications of sickle cell anemia, chest syndrome. This would be similar to a pneumonia. You'd see pain, fever, cough, hypoxia, and wheezing. CVA, we have other things listed. I want to say that page number is 1277 for that. One of the things that they also talk about is vaso-occlusive crisis. This is when our patients with sickle cell, they're in crisis and they have severe pain, fever, swelling of the hands and the feet, and the joints from hypoxia. We'll see if that hypoxia isn't corrected, we'll see ischemia, which could lead to necrosis as well. The prognosis of sickle cell anemia depends on the severity of the disease. Typically, the cause of death is infection. The spleen is non-functioning by age 5 due to scarring. But again, like I said, most of our sickle cell patients do live into adulthood related to that antibiotic therapy. Some of the things that we are going to talk about in regards to their care would be they're at high risk for altered tissue perfusion. They're at high risk for fluid volume deficit. They are at, we worry about pain, high risk for infection. We've got knowledge deficit and impaired physical mobility. Okay, so let's kind of review here what we got with sickle cell anemia. We've got sickling, so the normal hemoglobin is replaced by an abnormal sickled hemoglobin, which leads to pathologic changes. Remember, we talked about that increased blood viscosity and increased RBC destruction. And we know with that blood viscosity, we have thickened blood that slows circulation, causes capillary stasis, and they're at risk for obstruction and thrombosis. We talked about the sickled hemoglobin having a shorter cell life, 10 to 20 days instead of the normal 120 days. And don't forget, sickle cells can resume normal shape once we get these patients rehydrated and reoxygenated. So how do we prevent sickling? We want to avoid conditions of low oxygen tension, which causes RBCs to assume a sickled shape. And when that happens, we have altered tissue perfusion. So think of the cascade events when we have altered tissue perfusion. We want to provide continuous extra fluids to prevent dehydration. Again, we want to make sure that we don't have that increased blood viscosity, okay? So if we're worried about dehydration, think of fluid volume deficit in all that cascade of events. We want to make sure that we're avoiding activities that may result in overheating to prevent dehydration. Appropriate clothing, limit the time in the sun, bed rest, hospitalization to minimize oxygenation use. Hydroxyurea is a medication we use to decrease sickling episodes. We need to keep an eye on their electrolytes and replace those as needed. Don't forget, I know we talk about giving oxygen, but remember, giving the oxygen here really does little to help. We need to rehydrate them and do those other things to prevent sickling once sickling has occurred, okay? I believe I mentioned page 1277 for the vaso-occlusive crisis. Let's see here, I believe there's a box 43-2. The vascular organs are most affected when we have vaso-occlusive crisis. I kind of went over what your signs and symptoms and what to expect. The fix for vaso-occlusive crisis is giving IV fluids and pain management, okay? We could see blood lost in the urine with vaso-occlusive crisis because of that ischemic kidney. Don't forget, those end organs will not be perfused, okay? So we could see hematuria. We could see increased liver enzymes. Once the liver becomes ischemic, don't forget, our blood flow is staying in our heart and our lungs, okay? All right, maintaining an infection-free state. Don't forget, infection and fever lead to a higher need for oxygen. Standard precautions, good hand washing technique, teach prevention of infection. That would be adequate nutrition, frequent medical checkups. Keep away from sources of known infection. Make sure their immunizations are up to date. We need to stress the need to report early signs of infection to the doctor. We need to balance prevention of infection with a child's need for a normal life. Remember, all of these conditions, we tend to want to keep these kids in a bubble, but we can't do that. We need to make sure they have a normal life as much as possible. Typically, patients with sickle cell will begin oral penicillin prophylactically by the age of 2 months. Our supportive therapy during crisis to minimize pain, provide bed rest, hospitalization during crisis to decrease the body's demand for oxygen, relieve pain by administering pain medications. We want to handle gently and use proper positioning techniques. We want to apply heat. Remember, we never want to use cold here because cold leads to vasoconstriction. Vasoconstriction leads to sickling. So we're applying heat to painful areas to increase blood flow and that oxygen supply. We can administer oxygen to relieve hypoxia and prevent further sickling. Administer blood transfusions to correct severe anemia. Don't forget, we're looking at severe anemia because we talked about those dangers from multiple blood transfusions over a long period of time. We're going to monitor our fluid and electrolyte balance. So we're going to look at our INO and our weight and those electrolytes. We're going to perform ADLs for the child if they're unable due to impaired physical mobility, but we want to encourage self-care as soon as possible. Again, we talked about those other complications, the acute chest syndrome, which is very similar to a pneumonia, and then a CVA or stroke. And those are mentioned in the chapter as well.